We start your get your second year rolling. So we're going to look at respiratory physiology. This is Dr. Dean. Sorry. So respiratory physiology is one of the core topics of physiology. As you know, it is one of the vital systems. And I would beg your kind attention so that you can understand its significance in the whole homeostasis of the body. And also, it will put you in very good place to correlate the following, the subjects that are going to follow: cardiac physiology, GIT, etc. So, what is respiration? Respiration, to start with, is simply, as a definition, all those processes that maintain the normal levels of oxygen and carbon dioxide in the body. As a definition, that is respiration. Yeah, and that's what respiratory physiology is all about. But usually you find that it is divided into internal, or what is called the oxidization of substrate to release energy, and also carbon dioxide and water. As you know, when oxygen reacts with the substrate, for example, glucose, products are water and carbon dioxide and energy. That is internal or cellular respiration. External respiration is what we are going to talk about today, is the absorption of oxygen and the removal of carbon dioxide from the body and all the processes in between. We breathe in, we breathe out. That is just the external manifestation of all the respiratory processes. We will look at all the processes that are involved in absorbing oxygen and releasing carbon dioxide from the body. What is the purpose of respiration? The purpose of respiration is to maintain the arterial levels of oxygen and the arterial levels of carbon dioxide, and to some extent, pH. And it is in that order. The prime purpose of respiration is to maintain adequate oxygenation of the tissues, and that is done by maintaining oxygen levels in the arterial blood. And of course, then the job of distributing that is not the job of the respiratory system, that is the job of the cardiovascular system, which you will cover later on. To achieve this function, there are 4 crucial steps which you need to understand. The first step is ventilation. Now, ventilation is, by definition, the act of breathing in and out. And this is what is the external manifestation of all these processes. We breathe in, we breathe out, we breathe in, breathe out. And that constant inspiration and expiration is called ventilation. But it is not synonymous with respiration. Many people think that respiration is synonymous with ventilation, but no, ventilation is but one process of respiration. Once the gases are taken into the lungs, there is the second step of respiration called diffusion. Now, diffusion is a totally non-active process. It's dependent only on gas concentrations, and we shall see that oxygen diffuses from the alveoli into the pulmonary capillaries, and carbon dioxide, on the other hand, diffuses in the other direction, from the pulmonary capillaries into the alveolar gas space. This process is called diffusion, and it is a very important second step of respiration. Once the gases are in the blood, they have to be transported. Oxygen has to be transported from the lungs to the tissues, because that's where oxygen has to be delivered. And carbon dioxide, on the other hand, has to be transported from the tissues to the lungs so that it can be blown out, so to speak. That process is called blood gas transport, and we shall see how that works in due course. Once the gases reach the tissue level, there is the tissue gas exchange, which also is largely diffusion based. But in this case, what is happening is that oxygen from the blood would diffuse into the cells that need the oxygen, and the byproduct of respiration, which is carbon dioxide, would then diffuse out of the cells into the blood to be carried back to the lungs. These 4 steps are the core of understanding respiration: ventilation, diffusion, blood gas transport, tissue gas exchange. And then the last bit is for us to understand the control of all these steps, which we will do at the end of the series of lectures. This is just summarizing the 4 steps that I've mentioned to you. The first one is pulmonary ventilation. You get gases into the lungs, and then from the lungs, you get diffusion, where oxygen enters into the blood, carbon dioxide comes out of the blood. This blood is the gases within the blood are then transported, and then at tissue level, the gas oxygen enters the tissues and carbon dioxide comes out of the tissues. Now, to understand the physiology, we'll just briefly have a look at the respiratory anatomy relevant to our understanding of physiology. The respiratory system basically starts at the tip of the nose up to the tip of the last alveoli. When we breathe in, our nose is designed for breathing in, and we shall look at various functions of the nose. One is, of course, simply conduction, but it also filters, warms, humidifies the air, and then it passes to the nasopharynx, oropharynx, and laryngopharynx. And that is where the air is then channeled into the larynx, trachea, and into the lower respiratory tract. The parts which are above the chest are called the upper respiratory tract, and the parts of the respiratory system which are within the chest are called the lower respiratory tract. And what is important for you to realize, a bit of the trachea is outside the chest, and a bit of the trachea is within the chest. And there are differences, as we shall see later when we talk about functions of the larynx, in not only the physiology, but even the pathophysiology is different at the upper respiratory tract and in the lower respiratory tract. So once we reach the lower respiratory tract, the trachea then divides into the left and right bronchi. And by gradual divisions, the airways become smaller and smaller and smaller until at the last divisions, it is only a 1 cell thick membrane. And that membrane exists in small bulbous dilatations, and that those are what we call the alveoli. This is a slightly detailed look at the nose, and this is the turbinates, nasopharynx, oropharynx, laryngopharynx. And as I mentioned to you, nose, apart from simply being a passageway for the air, it cleans the air, humidifies the air, warms the air, and of course, lest we forget, it's very important for olfaction. And it does also give resonance to speech. And when one has a cold, one sounds quite different, so-called hyponasal speech. Yeah, so those are the various functions of the nose. The one which is mainly significant are in terms of respiration are the first 4. And the point is that the air has to, this is air conditioning. The air has to reach the lungs in a way that it does not traumatize the alveoli. It should be humidified 100%. It should be cleaned. Dust should not enter the lungs. And also the cold temperature does affect the clearance of mucus, for example. The cilia are sensitive to temperature changes. The pharynx, as far as respiration is concerned, is a common passage for the digestive and respiratory systems. And there is some humidification simply because air is moving over a moist mucous membrane. Apart from that, there may be some sedimentation of suspended dust as well. Yeah. Now let us go to the tracheobronchial tree. We must understand that once you have the trachea, it actually divides 23 times. And every time it keeps dividing, it becomes thinner as well as narrower. These divisions, the ones that only conduct the air and are not involved in diffusion, are called the conducting zone or conductive zone. And this stretches right from the trachea to the terminal bronchioles. And the passages, of course, it's a passageway for the air movement. And they have pieces of cartilage which holds the tube system open. And there's also smooth muscles in the bronchioles that control the diameter of the bronchioles. The respiratory zone starts at what are called the respiratory bronchioles. That's when the first alveoli are seen in the respiratory tree, so to speak. And that is where the respiratory exchange is going to take place. Yeah, and this is the so-called site for gas exchange. This is where the business end of the respiratory tree. And yeah, sorry for that. I just had to attend to something small. That is a pictorial depiction of the tracheobronchial tree. You can see that the trachea has incomplete rings. There's only one complete ring, and that is the cricoid cartilage. We'll talk about it when we do laryngeal physiology. And then all these are cartilaginous rings. And later on, there are even just pieces of cartilage that help to stiffen. And then once the alveoli start, that is called the respiratory bronchioles. And in the end, you have the small, what are called pulmonary lobules. Yeah. This is how the lungs look. And it's generally divided into lobes, where the left lung is a superior and an inferior lobe. The right lung has a superior, middle, and inferior lobe. This is where the heart sits. The superior portions of the lobes are called the apexes, or the apices of the lungs, and the inferior portions are called the base. Yeah, this is where the diaphragm would be placed. It's a cross-section of the chest, which shows you how the lungs are sort of in an air and watertight cavity, the chest cavity, and the lungs have a covering of membrane called the pleural membrane, both the right and the left lungs. This is, of course, the heart. And there's a potential space. This is called the pleural space. And it is in this space you have a slight amount of fluid, and the lungs are able to slide freely within the chest wall because of this lubricating pleural fluid. And we shall see that the pleural space, although it's a potential space because they're stuck together by surface tension, they can become significant in certain pathological situations. Yeah, this is also to show you how the alveoli are small, single-celled sacs, and they're only one cell thick. And you have, of course, cellular elements like macrophages. And you have every alveolar is covered with a network of pulmonary vessels. You have about 150 million alveoli in each lungs, and they're very tiny, 0.3 millimeters, and thin, extremely thin, 0.5 microns. And the overall surface area of the respiratory epithelium is 70 meters squared. It's a very large surface area. And as we shall see, the thinness and the large surface area is an adaptation, an evolutionary adaptation towards assisting in the diffusion of gases. This is a cross-sectional view of the histological features of respiratory epithelium. And this respiratory epithelium, as you can see, has these goblet cells. This is a stain and this is a diagram. Goblet cells produce mucus, which is in two layers, a mucoid layer on top and a watery saline layer. And this, it also helps to trap dust. And these cilia, which are like hair-like projections of the cells, beat in a sweeping motion to move the mucus towards the pharynx. So if this respiratory epithelium is in the nose, the cilia beat backwards towards the pharynx. And if these cilia are within the lower respiratory tract, they beat upwards. And this is what helps the mucus to gradually, collect in your throat. And subconsciously, we are always, this clearing of the throat is actually taking a little bit of mucus that has reached the vocal cords and putting it to the oropharynx and simply swallowing it. This happens every second of our lives. We don't even think about it. In certain disease situations, the mucus may get stuck or the cilia may become less effective, and then we have difficulty in removing the mucus from the lungs. This is an electromicrograph picture of the network of alveoli in the lungs. This is one alveolus. Right. The bronchial smooth muscle that I mentioned earlier is innervated by the autonomic nervous system. And this is a bit different. In fact, it's opposite to the innervation of blood vessels, where sympathetic discharge to the lungs, to the bronchial musculature, will cause bronchodilation, whereas parasympathetic discharge will cause bronchoconstriction. Yeah? If you remember your autonomic nervous system, in blood vessels, it's the other way around. Blood vessels, the sympathetic discharge causes vasoconstriction. Yeah? And as far as the bronchial musculature is concerned, sympathetic causes bronchodilation. There are other means of affecting the bronchial passages. There are substances and various chemicals, which, for example, VIP mediates vasodilation. Certain leukotrienes and substance P cause vasoconstriction. All these are important in pathophysiological situations. Leukotrienes, for example, are produced during allergic reactions, and they may cause bronchoconstriction, which may result in for example, bronchitis or bronchial asthma. Yeah. Yeah, there's a typographical error. We are not talking about vasodilation. We are talking about bronchodilation. Okay. Within this respiratory tract, there are other cellular components such as macrophages, lymphocytes, APUD cells, mast cells. All of these have their various roles, which you have well acquainted with. Okay, with that basic anatomy and basic principles of respiration, now we come to the physics of gases. It's very important for you to learn a few laws. And let me say at the outset that it's not so important to learn the names of the laws as it is what the law means. Yeah, I mean, they're mostly named after the people who popularized the law. Most of them are Englishmen. I'm told if you study in some of the so-called Eastern Bloc countries, they are named by different people, so it doesn't matter. So let's start. The first one is Boyle's law. Boyle's law states that pressure and volume are inversely proportional. So that if you have a volume and a certain pressure, so this lid on this gas is exerting a certain pressure, you have a certain volume. If you increase the pressure, the volume goes down. Conversely, if the volume increases, the pressure falls. So there's an inverse relationship between pressure and volume. This is very important in ventilation, as we shall see in due course. Boyle's law. Again, Boyle's name is not important. The law is important, that pressure and volume are inversely proportional. The second law is called Dalton's law. And the Dalton's law mainly talks about partial pressures of gases in a mixture of gases. Very seldom in a natural environment do we have pure gases. The air that we are breathing is also a mixture of gases. And Dalton's law says that in a mixture of gases, the pressure that a particular gas exerts, which is called its partial pressure, is the total pressure times the fraction of the total gas that gas forms. Meaning that, for example, oxygen has 20% of the gas in atmosphere. Yeah, it's of the atmospheric gas, only about 20%, 20.9 actually, normally we say 21% is oxygen. And the total pressure of the atmospheric gases, which is around 760 millimeters of mercury, oxygen would then be approximately 21% of that, which works to 160 millimeters of mercury. So that the gas, the partial pressure of a gas is actually the amount of pressure which is available to us to utilize for our absorptive purposes. Yeah, you can see that nitrogen, for example, is almost 80%. So naturally, atmospheric pressure is largely contributed by nitrogen. So this 160 is a nice figure to remember. This 160 is the amount of oxygen partial pressure that is available to us. Okay, so please remember Dalton's law of partial pressures. The third law is Henry's law. Now, Henry's law refers to gases in solution. Now, gases in solution really, what it says is that the concentration of a gas in solution would depend on the partial pressure of the gas above the solution and times the solubility coefficient of that gas. Another way of saying it is that in order for gas to dissolve in a fluid, and gases do dissolve in fluid, just like solids do, there has to be a pressure, and the amount of gas that would dissolve would be dependent on the pressure above the fluid. This is why your soda bottles, yeah, we say they are bottled under pressure. So when you look at a bottle of Coke, for example, and it's just lying still on the table, you don't see any bubbles of gases. But once you release the pressure by opening the bottle top, immediately you find gases bubbling out of the solution. It is because that gas, which in this case is carbon dioxide, was held in solution by the high pressure above the solution. And when you release that pressure, it bubbles out of solution. Yeah. The second sort of result, or the second feature that we notice in Henry's law is that when the gas is in solution, it will also exert a pressure. And that pressure that it will exert would be the same as the pressure above the solution. Yeah. So, for example, if the pressure of oxygen above a certain solution is 100 millimeters of mercury, some oxygen would dissolve depending on the solubility coefficient of oxygen, but the amount of oxygen that has dissolved would still give out a pressure or have a pressure which would be exactly the same as the one above it, which obviously is true because there has to be equilibrium. Yeah, that's how the two gases would remain in equilibrium. So please remember Henry's law of gases in solution and solubility coefficient. This is just a diagram showing you that carbon dioxide, for example, is much more soluble than oxygen, so that more carbon dioxide dissolves in water as compared to oxygen if it is subjected to the same amount of pressure. Further, one must understand what is diffusion. And unfortunately, there's a bit of confusion about diffusion. And I want us to be very clear what is diffusion. Diffusion basically is the movement of gas which occurs due to differences in concentration between one area of that gas and another area where the gas could be. Sorry. So for example, you have a gas which is separated from this other area by a membrane. Because the gas, if you remember from your high school physics, always the particles are moving around. They will tend to move and they will tend to diffuse, move into the available space until such a time that the concentration gradient is the same. That is very important to realize. And moreover, not only can diffusion occur due to concentration gradient, it can also occur due to a pressure gradient. So if there's more pressure, and from Henry's law, we know that pressure, and from Dalton's law, we know that pressure and concentration are related. Concentration and pressure are related. So if more the pressure, more diffusion would occur. More the concentration, more diffusion would occur. This is very important because you will see diffusion as a principle of physics is how gases are going to move across semi-permeable membranes. So you can see that, look, if the distance is only 1 micron, it takes about 0.5 over milliseconds, rather fast. Yeah. So diffusion occurs rather fast. It's beneficial for the exchange of gases. Another law, which is the Fick's law of diffusion, basically says that the rate of diffusion of a particular gas across a semi-permeable membrane would be proportional. So rate of diffusion would be proportional to the area across which it is diffusing times the concentration gradient, yeah, over the distance. The distance in this case means the thickness of the alveoli. In our case, the alveoli. Yeah. So larger the area, more the concentration gradient, thinner the partition, more the diffusion. And as I mentioned to you a little earlier, strategy in the evolution of our respiratory anatomy is that there's a large surface area, almost 70 meters squared, and the distance very, very thin, just one cell thick. I mean, it can't get much thinner than that at the alveoli, so that all of that promotes diffusion at the alveoli. This is a diagrammatic look at the distance where diffusion takes place at the alveoli. If this is the alveolar side and this is the capillary side. So we shall look at this a bit later on, the so-called blood gas barrier, BGB. And the distance is 1 micron or even less. When you find that the membranes of basement membranes of the capillaries and the alveoli are actually fused, making that extremely thin. Some other gas laws which we don't use them much. It's Charles's law, which says that if the pressure is constant, temperature is proportional to volume. It doesn't affect us much. And then there's the general gas law, which you might also recall from your A levels, is that or your O levels, that the pressure times volume over the temperature is a constant, which is called the gas constant. Okay, good. So we'll take some questions. This is the first lecture. Can take questions, then we take a screen break. Let me look at the chat. I think people can post the questions on the chat so that I can answer them with relevant to what we have talked so far. Any questions? Okay, so no problem. There are no questions, which is fine. Let's take a 5-minute screen break. Walk away from your devices. Don't use them. Don't start WhatsApping now. Give your eyes a break. Then we come back. Okay. Okay, so let's carry on. So we've basically at this stage looked at sorry, there's a question here. Does the size of the gas molecule affect the accuracy of these laws? It certainly affects the application of these laws, not the accuracy. I mean, smaller molecules generally tend to be more diffusible than larger molecules. Yeah. So we looked at the definitions of respiration, the basic anatomy, and we've also looked at the some basic gas laws. Now we can get into the subject itself. First subject is ventilation, pulmonary ventilation, which, as I told you, is defined as the process of breathing in and out. Yeah? When we breathe in and we breathe out, inspiration, expiration, that is what is ventilation. It is the first step in the respiratory processes. Yeah, and I repeat, it is not synonymous with respiration. In order for ventilation to take place, the ventilation apparatus must be in its proper condition. What is this ventilation apparatus? The chest wall, which is largely constructed by the ribs, the intercostal muscles. And then we have the lungs. In between the lungs and the chest wall, you have the pleura, the parietal and the visceral pleura. And between those two, we have this potential pleural space. And these converts the pleural cavity into a compartment which has its own pressures and own volumes. And how are these volumes and these pressures changed? It is by the muscles of respiration, which can be divided into inspiratory and expiratory muscles. So that this is now a diagrammatic look at the ventilatory apparatus. And the main inspiratory muscle, my friends, is the diaphragm. And how the diaphragm will work, we'll come to it. But basically, the diaphragm can change from a dome-shaped, note that it's dome, D-O-M-E. Many of you write doom in examination. It's not dome-shaped. It is dome-shaped, D-O-M-E. And when it contracts, it becomes flat. So it actually increases the volume above it. Yeah. The other inspiratory muscles are the external intercostals, which tend to bucket handle the rib cage to make it of a larger volume. The scalenes and the sternocleidomastoids help to stabilize the chest wall and are sometimes referred to as the accessory muscles of respiration. The chief expiratory muscle is the abdominal muscle, and we shall just in a few seconds see how it works. And in addition, it is helped by the internal intercostals. If you look at the structure and the pressures within the pleural space, you find that if these are the ribs, this is the lung, and you have the pleural space in between. Pleural space generally has a negative pressure. Why is it negative? Because at equilibrium, the ribs tend to recoil outwards and the lungs tend to recoil inwards. And because there's an opposing force, they're held together by the surface tension of the fluid. But within the pleural space, there is a negative pressure. This is important because if there is an perforation and the pleural space connects to the atmospheric pressure, the negative pressure will immediately pull air in and the lung would collapse. Yeah, this is a situation which in pathophysiology is called pneumothorax. And this pneumothorax usually occurs only on one side unless there's gross injury. Of course, bilateral pneumothorax would immediately be one unilateral pneumothorax. Ways and means you will learn to help the lung re-inflate. Yeah, to gradually get the air out from the pleural space. So this is a negative pressure, but that pleural space also has that fluid, which I told you allows for allows for sliding of the lungs as it increases its volume. And this is the diaphragm, which I mentioned to you, which is a half a dome here. Of course, the other dome would be on the other side. So let us see what happens in one cycle of respiration. This is someone who is just breathed out. And at equilibrium, you find that the diaphragm is dome-shaped. Yeah, and the lungs are in total balance with the chest cavities. When one breathes in, the first step is that the diaphragm contracts. When the diaphragm contracts, it moves downwards. When it moves downwards, it creates this more volume within the chest cavity. That volume increase by Boyle's law causes a fall in pressure within the lungs. It is that fall in pressure that sucks air from the atmosphere into the lungs. Yeah, and this is how you take your breath. You simply increase the volume of the chest, primarily by the diaphragm, maybe also by the external intercostals, and that allows the pressure to drop and allows the volume of air to rush into the lungs. Once one has breathed in, you are actually out of equilibrium because at the end of inspiration, your abdominal contents have been pressed, the chest has been pulled further out, the lung has got further inflated. Then expiration, basically all the diaphragm has to do is simply relax. When it relaxes, the abdominal contents recoil it to its dome shape, reducing the volume within the lungs, increasing the pressure. Yeah, Boyle's law says less volume, more pressure. And that increase of volume is what drives the air out of the lungs. If there's additional need for a larger expulsive effort, then the abdominal muscles can contract. And also the internal intercostals can contract, push more to reduce the volume further and push the air out with more force. This is just showing you the same process from a different angle, that not only does the diaphragm go downwards and hence increases the volume, but you can also have the ribs. They move in what is called the bucket handle fashion. You can see that if it moves from this position to that position, there's a lateral increase in the volume. Yeah, a lateral increase in the chest diameter laterally, and that increases the volume. So to summarize, inspiration is a rise in volume, fall in pressure, air rushes in from the atmosphere. Expiration, there's a fall in volume of the lungs, pressure increases, air rushes out. During quiet breathing, only inspiration is active and expiration is totally passive by recoil. You simply stop inspirating and the recoil will help the air to come out. And it's only in forced breathing or when we're using breathing for other purposes, for example, speaking or shouting or playing a medical instrument, then you will both inspiration and expiration would be active, as well as the accessory muscles which I mentioned earlier would be used. So that is clear. Then let us move to the factors that affect ventilation, and there are 5 different factors that are sort of either helping or act as an impedance to the act of inspiration and expiration, and we must understand all of these one by one. So let's just first look at what we call the work of breathing. The work of breathing, when someone is breathing, there's a certain amount of force, an amount of energy that has to be expended when someone is breathing. That energy that is expended is needed, one, against compliance, because the lung and all the other structures in the ventilatory apparatus have elastic properties. So you need to have the compliance work to overcome that, number one. Number two, you also must overcome the viscosity of the lung and the chest wall. Yeah. So there's not only the elastic nature of the chest wall, but simply the thickness and the lack of certain structures are not elastic, and we must overcome that viscous nature of the lungs and the chest wall. And thirdly, there's what we call airway resistance work. Airway resistance work is work done against simple resistance that comes from the air moving through the small, thin airways of the respiratory and the bronchial tree. If you look at the change of the volume of a lung during inspiration and during expiration, you get a very classical looking curve, which shows that the lung behaves that during inspiration, it behaves differently. So as the pressure changes, trans-lung pressure, the volume rises to its maximum, it's a percentage. And then, but when you remove air from the lung, it doesn't follow the same curve. Yeah? This is sometimes called a hysteresis loop. And this, it follows a different route. It's because when the lung is expanding, there is a change even in the alignment of the elastic structures. So when it is going back to its original form, it's not the same lung, so to speak, in structural descriptive terms as it had started there. Of course, when it comes back, by that time now the structures have gone back to normal. So again, it will follow this loop, but on its way back, it follows a different loop, and on the way forward, it follows a different one. Yeah. Lungs are very compliant for that matter, and you can see that the change in volume is about almost 2 liters per about 6 centimeters of water change in pressure. Just to give you an idea, at the moment we don't want to bring too much pathophysiology, but you find that in a normal person, that our lung volume curve someone has fibrosis, certain diseases causes fibrosis of the lungs, it will be much lower. The compliance will be poorer. In conditions such as emphysema, where alveoli coalesce and form larger cavities rather than the small alveoli, you find lung compliance actually increases. Asthma also, you can see that the loop is simply occurring at a higher pressure, but the shape is almost the same as normal. Second factor, that of compliance. Second factor, surface tension. So what is surface tension to start with? Well, as the name implies, it is as if the surface of fluid is under tension. That's why these, what are called pond skaters, they can literally walk on water. Yeah, because they've got, their legs don't pierce the outside film. Question is, why is there like film like, there's no real film, but why is there a film-like feeling at the surface of water? And the reason is that the water molecules or any fluid molecules are always attracting each other. The upper surface is only attracted towards the deeper part of the surface of the fluid. So this surface gets under tension. It's as if the molecules are being pulled apart. And that being pulled apart creates a force. That force we call surface tension. This is why a drop of water forms, because the outer layer is being pulled in and then a drop can form and hold the water within it, almost like a little film. It's not a true film. It's simply a film of forces. Why is this important? It's important because if this is, let's imagine it's an alveoli. If the alveoli is full of air, it of course has a thin film of fluid. All our tissues, there's no life without water. All our tissues are moist. So there's a thin film of fluid, and there's a pressure that exists within the alveoli, and that pressure is generally is derived by 2P over R, where 2, the pressure is the pressure, P is the surface tension, and R is the radius. Why 2? Because there are 2, when there's a film of fluid, there'll be a film towards the cell wall side and towards the air side. So that's why you have to multiply by 2. The key to remember here is that the pressure created within any alveoli is dependent, yes, on the surface tension, but it's also dependent on the radius R. So the smaller the radius, look, higher the pressure. And what this means is that suppose you have another smaller alveolus here. The pressure here would be higher than the pressure in a larger alveolus. And what would then happen is that the air would actually go from the smaller alveoli into the large alveolus, resulting in collapse of the smaller alveolus. Obviously, this shouldn't happen. Yeah, this shouldn't happen. Otherwise, all the small alveoli would collapse. So, this is the danger of the surface tension, number one. Number two, the surface tension within the lungs make it harder for the alveoli to be expanded. Yeah, so that they are a challenge to the work of breathing. So 2 and 3, the negative pressure, which I'm mentioning here, it's all towards the center of the alveolus, may actually result in fluid being sucked from the tissues into the alveolus. This slide summarizes the 3 dangers of surface tension. 1, it increases the work of breathing. 2, it may result in the collapse of small alveoli. And 3, the negative pressure may result in fluid entering into the alveoli. Now, this is physics. We have to have fluid within the lungs. So surface tension may cause us all these difficulties. So as we were evolving our respiratory system, we evolved something that reduces the surface tension, and this is called surfactant. Surfactant, dipalmityl phosphatidylcholine, DPPC, is a secretion which is made by the type 2 pneumocytes within the respiratory system. And its structure, it has two parts. It has a hydrophilic part. Philia means to like something. Yeah. Hydrophilic part, and it has hydrophobic part, which doesn't like water. And this gives it the property of being like a detergent. When this kind of a substance is mixed with water, it reduces the surface tension. It breaks up that theoretical film, or rather that film-like forces at the surface, and reduces the surface tension. And surfactant is produced in each and every one of us. Sometimes if babies are born prematurely, their lungs haven't matured, they don't have surfactant, you get what is called the respiratory disease of the newborn, where the child can't breathe properly, struggles for every breath because the alveoli keep collapsing. The alveoli keep collapsing and surface tension holds them shut. Each breath is like his first and last breath. Yeah, he has to struggle with each breath. What happens in that example that I gave you? So if there's surfactant, you can see that this surfactant and this surfactant in a smaller alveoli, what will then happen is that the pressure will get equalized. Yeah, but the surface tension will be much reduced. The radius, of course, will still be different, but the tension, the T, surface tension would be less, and that would allow the pressures to be same, so the small alveoli will not empty into the large alveoli. 1, 2, there'll be a reduction of the negative pressure there, so fluid will not get sucked in from the tissues. And 3, the work of breathing will be better. So those are the 3 important facts that one has to remember about surfactant. It reduces surface tension, therefore increases compliance. So it reduces the work of breathing, stabilizes the alveoli. That law, by the way, the one of the pressure in the alveoli is called the law of Laplace. Laplace contrast to the names Laplace. It also helps keep the alveoli dry and helps pulmonary edema. And as I mentioned earlier, it is crucial for expanding the lungs when the lung collapse. When a baby is born, there's no air in the lungs. So all the lungs are collapsed. And open need to work against tension, and that's where surfactant comes in. Secondly, or rather, we come to now airway resistance. Yeah, we looked at compliance, we looked at surface tension. Now we are looking at conductive airway resistance. So when air moves through any vessel or any fluid moves through any vessel, there is a resistance. And this is another law, Puiseux. This word Puiseux is a French again. Notice the spelling. The double L in French becomes ye. So you don't say Puiseux, you say Puiseux. So Puiseux's law of fluid in vessels says that the resistance to flow of a fluid in any vessel would be 8 times rho L. Rho is the ratio of viscosity and density, and basically you can just say it is the viscosity, that for our purposes, divided by pi r to the power 4. The most crucial is the R4, which means that the thinner a vessel, the much higher the resistance. For example, if you lowered the radius by just half, the resistance, the big R, would increase the power 4, 2 times 2 times 2 times 2, which is 16 times. So if the radius is half, the resistance would increase 16 times. This is important because as we are going towards the alveoli, the bronchial aperture becomes smaller and smaller and smaller, thereby resulting in more and more resistance. Agents, this is how we can make a mental image of it. Yeah, the gas is flowing through it. There's a fact, something that we call dynamic compression of airway. And how this works is that one would think that the alveoli is so weak when we expirate, why don't all the alveoli collapse? Because any pressure on the alveoli should make them collapse. And that is where some very beautiful, we call it evolution, we call it creation, it doesn't matter, it's the same thing. You find that certain parts of the terminal parts of the respiratory bronchial tree, you find that there are portions which are actually weaker, more collapsible than the alveoli. So as one expirates, there's a larger pressure within the lungs, you find that it compresses certain areas more than the alveoli. So this would collapse, but the alveoli don't collapse. In fact, there's certain amount of air, as we shall see later on, which can never be removed from the lungs, and that is due to what we call dynamic air pressure. There are regional differences in ventilation. If someone is being erect in anatomical position, the upper areas, the superior areas receive less ventilation. This is just, you see it is a partly anatomical, partly physiological, and the lower areas receive more ventilation. And if someone lies flat, let's say with his face upwards, find the anterior parts would receive less, the posterior parts achieve more ventilation. This is explained by the fact that the amount or the stage of expansion of the lungs at the apex and the base of the lungs is quite different. You find the upper areas are already in this part of the graph, so that they have less expansion, so there's less ventilation in the upper areas, whereas the base are less expanded at rest, so that they have a larger volume to expand when you take in breath. So it's simply that the apexes are at the higher point of the inspiratory curve of inflation of the lungs, and the bases are at a low point of the curve. Yeah, so this is a regional difference. These are some of the methods of measuring pulmonary volumes, and this previous times is to use the flotation spirometer, where you blow into a cylinder which floats, and as more air goes into the cylinder, that is connected to a pen. The pen can chart how much air is coming in and out. These days we do the whole thing electronically, and it's very much easier. You simply blow into a machine which analyzes your air moving in and out of the lungs. Just for our reference, there are some pressure changes. You can see the alveolar pressure in inspiration and expiration. That's how it changes. It becomes a little negative. 0 to start with, becomes a little negative as air comes in, and then during expiration it becomes a little positive. The intrapleural pressure, that is the pressure within the pleural space, you can see it becomes quite negative. And this is millimeters, centimeters of water, my friends. Yeah, 6 centimeters of water. And then during expiration, it goes back to the baseline. We had mentioned at least about negative 2 to 3 centimeters of water. And this is how the movement of air. Someone breathes in, about 500 mils comes in, and about 500 mils, of course, has to be expirate. I think that's the same kind of thing shown in another form. Right. So again, I would like us to take a little break. We're going in good time. Let me have a look at the chat. If there's some questions, you can please post them there and I can answer them for you. I agree with you. It's very difficult. This is even for me and even for you. So breaking a lot. Oh, am I breaking a lot, or are we taking a break too often? Was my sound breaking? Class rep?
Yeah.
Oh, sorry. Yeah, sometimes the internet fluctuates. Huh? I apologize for that. Is it a bit stable now?
Okay, I can still make out what you're saying. So yeah.
Oh no, that's terrible. Maybe what I can do is I'll switch off my video, because video takes up a lot of the bandwidth, and that may improve the sound quality. Does the sound quality get better now?
Yeah.
Is it a bit better now?
Yes.
Okay. Sorry for that. When I'm talking, you should have just interrupted and told me, Madam Class Rep. And hi, doctor. Is quiet breathing the one done during sleep? No, even at rest, when we're sitting and doing nothing, that is quiet breathing. In fact, sometimes during sleep, of course, it's also quiet, but you can get agitated depending on which kind of a dream you're having. But quiet breathing is one when no physical effort is being made. Please unshare, then share the screen. Again, I can't see the slides. Who is that? Can people see my slides?
Yes, we can see your slides.
Oh, okay. So I don't know. Maybe someone had a problem. Yeah, this question I'd already answered. Yeah, please don't. If I was breaking, the easiest tactic is to cut the video, because video uses more bandwidth than does audio. So I can save you from having to look at my increasingly bolding appearance, and let's listen to my voice. Why is intrapleural pressure negative? I think I told you that at rest, the lungs are a bit inflated and tend to recoil inwards, and the chest is a little constricted, tends to recoil outwards. But that's perfectly at balance by the lungs and the chest. So the pressure in the pleural space, it's not very high. It's only 2-3 centimeters of water. We're not talking about mercury, centimeters of mercury. Could you please go to the slide summarizing all 5 factors? Which 5 factors? The ones affecting the work of breathing. Okay, I'll do that. I can go back. This one. Compliance surface tension, airway resistance, the chest wall. We were talking. I think we didn't look at it as a separate topic. We covered it with lung and chest wall compliance and the regional differences. Okay, so let's take a small screen break. We meet, and then we will look at these pulmonary volumes and then I'm sure we can finish by 4. Okay. Pulmonary volumes are the various changes in volume that occur during the act of breathing. And they have very important physiological and pathophysiological significance. This is why we study them in quite a lot of detail. And we'll cover those. Let's see if we have time. Otherwise, I think we're meeting tomorrow. So we can do dead space and measurement tomorrow. I also know these afternoon lectures are quite taxing. So I want to finish before 4 so that you can take a break and be fresh for tomorrow as well. So these volumes and capacities, what are we talking about? It is the volume of air moving in and out of the lungs. This is a cornerstone diagram. I've been looking at this diagram for many, many years. And if you understand this diagram, you've understood all the volumes. Yeah. Now, to understand the diagram, you need to just understand how this diagram is obtained. So we are looking at the movement in and out of the person's lungs during breathing. So let's start with that one. Let's start at the end of normal expiration. Somebody has just let out a normal expiration. He's not exercising. He's not talking. He's just normal resting expiration. And then he takes a normal resting breath. That amount of air, which enters his lungs is called the tidal volume, TV, or sometimes V small t, tidal volume. In a 70 kilogram man, it is usually 500 mils. In females, it's slightly less. It's a physical, proportional to the physical stature of the person. Obviously, when he takes out that breath, the same amount of air will come out. So the amount of air moving in and out of the lungs during a resting inspiration, expiration is called the tidal volume, and it's about 500 mils. Let's say at the end of a normal expiration, the person removes all the air that he can possibly remove from his lungs. That will be called the expiratory reserve volume. It is approximately 1.1 liters, 1100 mils. What have we done? We have removed at the end of an expiration. That's important that you remember you've started it. You've just removed air, and then you remove whatever you can. You can try it as you're sitting. You can remove all the air you can from your body. That will be only 1.1 liters. And then, of course, you will recover it in your next breath. That is called expiratory reserve volume, because that's what it is. It's a reserve of expiration. Then we go to the other side, that if at the end of a normal expiration or a resting expiration, everything here is normal, at the end of a resting inspiration, you then try to take as much air as possible in your lungs. That is called the inspiratory reserve volume, and it measures about 3 liters. So we have a very large inspiratory reserve capacity, volume, which is 3 liters. And of course, then you will remove it in your next breath. If you add all those volumes which I've mentioned so far, that means the total amount of air that you can take in and out of the lungs, that is called the vital capacity. So that if you have maximum inspiration followed by a maximum expiration, or vice versa, the amount of air that can move in and out of a person's lungs is 4.6 liters. No matter what you do, you cannot remove a certain amount of volume of air from your lungs And that cannot be measured directly. We will see later on how these are measured, but that's called the residual volume of the lungs. That residual volume is about 1.2 liters. During resting breathing, there's a certain amount of air which the lung holds. That is equal to the residual volume plus the expiratory reserve volume, and that's called the functional residual capacity. Whenever we talk about capacity, capacity means you are adding other volumes in terms of respiratory physiology. Yeah. So if you add expiratory reserve volume to residual volume, you find that you have functional residual capacity. It is this tank of air, which is approximately 2.3. Normally, we tell people to remember 2 liters. 2 liters of air into which you will, with each breath, give 500 more and remove 500 with each breath. So you're changing about 25%. You're not changing the whole composition of your air. And sometimes this air which is in contact with the alveoli is also called your alveolar air. That the amount of air that is constantly in contact with alveoli is your functional residual capacity. If you add all the volumes, including the residual volume, you get the total lung capacity. Sometimes is simply called the total lung volume, which is in an adult about 6 liters. We ask people to remember, whole numbers, 6 liters, 5.8 to 6 liters. So please understand these: tidal volume, expiratory reserve volume, inspiratory reserve volume, vital capacity. Vital capacity is maximum expiration followed by maximum inspiration, or maximum inspiration followed by maximum expiration, the total amount of air that can go in and out of the lungs. Then we have functional residual capacity, is the volume of air that exists within the lung during normal resting respiratory effort. Residual volume, something that cannot be removed from the lungs due to the dynamic airway compression, about 1.2 liters, and the total lung capacity about 5.8 to 6 liters. Please remember this, yeah? Because each time we breathe, or rather in each minute, we take a certain number of breaths. Generally, they range between 10 to 12 breaths per minute. And very, trained athletes, the breathing rate actually falls. But in an average person, about 12 breaths times 0.5 liters per breath, you find that you get a rate of about 6 liters per minute of air going in and out of the lungs. That is called the respiratory minute volume. Respiratory minute volume, the amount of air going in and out of the lungs at rest in a minute. The whole point is that look at the amount of reserve we have. This is why when we exercise but need more air, then our tidal volume increases. When we're tired, we're breathing. Not only are we inspirating more, we're expirating more. So our tidal volume would be higher. If you're extremely, exercising at peak level, you have the ability to actually have a vital capacity. Total, your tidal volume theoretically could be as big as vital capacity. You can move in almost 4.6 liters in and out of the lungs. So we have a large physiological reserve. We are healthy as long as that reserve is not breached. Okay, please remember these lung volumes. This is just a revision. Tidal volume, volume of air inspired or expired is normal. Replace normal with resting inspiration or expiration. Inspiratory reserve volume, amount of air inspired forcefully after inspiration of a resting tidal volume. Expiratory reserve volume, amount of air forcefully expirated after expiration of a resting tidal volume. Residual volume, volume of air remaining in respiratory capacities and lungs after the most forceful expiration. This is a volume that we cannot remove from the lung in health. Then we have the various capacities, inspiratory capacities, tidal volume plus inspiratory reserve volume. It's quite easy to remember actually once you just make a mental picture. Is functional residual capacity is how much expirate is the expiratory reserve volume plus the residual volume. And vital capacity is sum of inspiratory reserve volume, tidal volume, and expiratory reserve volume. The amount of air, maximum amount of air that can move in and out of the lungs. And then we have the total lung capacity, which sometimes is just simply called the total lung volume, with the sum of the inspiratory, expiratory reserve volumes plus the tidal volume and residual volume. Yeah, just a revision. But the diagram summarizes everything. Yeah. Okay, what's the difference between minute and alveolar ventilation? Minute ventilation, I already mentioned to you, the total amount of air that moves out of the respiratory system per minute. And at rest, it's about 6 liters per minute. Now, the interesting thing is that, well, this is derived by the respiratory rate times the number of breaths per minute. But part of the respiratory system is not in contact with the alveoli. So when we take that 500 mils, not all of that 500 mils reaches the alveoli. So how much does not reach? It's actually 150 mils. So you find that only 350 mils actually reaches the part of the lungs that contain the alveoli. So you find that the alveolar ventilation then is the amount of air that reaches the alveoli per minute. And it is usually 350 mils times 12, not 500 times 12. Oh, sorry. $350 times 12 comes to approximately 4 liters per minute. Okay, not 6 liters per minute. I'm just giving you a rough figure. That is called the alveolar ventilation. So the amount of air moving in and out of the lungs, which actually gets into contact with the alveoli, is 350 times 12, okay, not 500 times 12. That's the difference between minute and alveolar ventilation. This is another way of understanding these volumes, which you can just see that this is, see, if you have dead space, and you have the residual volume, expiratory reserve volume, tidal volume, and inspiratory reserve volume. Some people find it easier to understand, but I think to me that diagram explains everything. As I told you, the volumes in females generally is a bit smaller because of the smaller physical stature of females. And although the tidal volume is not very different, but the inspiratory capacity is less, functional residual capacity is less, and of course the total lung capacity is also less, yeah, depending on the size of the female. Yeah. So this we're talking about is your average 70 kilogram male. Yeah. Of course, you may have a tall 80 kilogram female. Her pulmonary volumes might be even bigger than this 70 kilogram male. So this is a physical attribute. It's not as in terms of there's not a sexual difference in terms of something to do with the hormones. It's simply physical. Okay, I think we can discuss dead space. I think you will understand. I don't know, how are people feeling? Today we are going at a good rate. Or should we I think let me just talk a little bit about dead space, and then we'll go into more detail tomorrow, because I wanted to stop at 4 for you. Let us define dead space and the types of dead space, but then the measurement and some of its details we can look at tomorrow. Dead space, my friends, is the portion of the airway or the volume of the airway that does not participate in gaseous exchange. Meaning that, of course, there's air in our airway, that's why it's called airway. But some of it is not participating in gaseous exchange. That amount of gases which don't participate in any gaseous exchange is called dead space. So where is this dead space? One must understand. There are two types of dead space. There is anatomical dead space. And this is the portion of airway that does not have alveoli and therefore cannot participate in gaseous exchange. I mean, there's some parts of the airway, the nose, for example, the pharynx, the trachea, there are no alveoli. The alveoli, as I told you, start way down at the respiratory bronchioles. So there are no alveoli. Amount of air that is occupying that portion of the airway is 150 mils. That is the same 150 mils which I said does not reach the alveoli with each breath. And we said that only 350 goes and meets the alveolar in each breath that we take. So anatomical dead space is 150 mils. And it generally is all that column of air right from the tip of our nose right to the respiratory bronchioles. All that on both sides amounts to 150 mils. The second dead space, and this is where again there's some confusion, and I want to clear the confusion right at the start. It is called physiological dead space. And physiological dead space is synonymous with total dead space. So if someone says physiological dead space or total dead space, we are referring to the same volume of air. They are synonymous. Okay, please remember this, people. That's the biggest confusion people have about dead space. That we have talked about anatomical dead space. The next dead space is total dead space, also called physiological dead space. Now, there's a formula relating physiological dead space to anatomical dead space. Physiological or total dead space is equal to anatomical dead space plus alveolar dead space. Now, that's the third type of dead space. We already know what is anatomical dead space. Alveolar dead space is the amount of gas which is in contact with the alveoli, but still doesn't participate in exchange. Now, why should that be happening? Why should that be occurring? Why should that happen? The reason is that the alveoli may be diseased. They may be a very thick barrier. Maybe there's inflammation, or they're full of fluid, or there's no circulation to carry the gas away. So alveolar dead space is a disease phenomenon, such that if in health alveolar dead space is 0, then the physiological dead space and anatomical dead space in health is equal. Although they are defined differently, you would have to say that total dead space or physiological dead space is anatomical plus alveolar dead space. But then you must further qualify and understand that alveolar dead space generally is close to 0. So in health, total dead space is equal to anatomical dead space. It's only if the alveoli have a problem, such as lack of circulation, they are swollen, edematous, or there's fluid within them, then alveolar dead space will rise. When we look at a single breath, now you can understand better what happens. Let's start here. Take one breath, 500 mils. 500 mils enters the lungs. 150 remains in the dead space. This is where that other circular diagram becomes useful. 350 mils of fresh air, fresh meaning full of oxygen reaches the alveoli. And it enters this, what we call alveolar air, or what we call the the functional capacity, functional reserve capacity, that this one. So you add 350 to it. Then the situation you are in, that you have increased that functional residual capacity to 2.7 liters. And then when you exhale, you will push out the air from the dead space, and the anatomical dead space will now be filled with the so-called stale air from the alveoli. Why do we call it stale? Because from it, the air from which oxygen has been extracted, and then you are back here. So this cycle keeps on repeating. What you have to remember here is that 150 doesn't ever reach the alveoli. Only 350 is reaching the alveoli. And when you breathe out, you actually breathe out stale air from the deep parts of your lungs. But not that it has zero oxygen. Expiratory air still has about 16 to 70% oxygen. That is why we can continue using our expired air for CPR, for example. Yeah. This diagram shows what happens to the dead space. Okay, I think I want to stop there. We will look at this tomorrow. I know people are getting tired. I'm feeling it even on the, if I'm tired, everyone else must be tired as well. So my friends, with your permission, I think, let me see if there's any questions for me, and otherwise then we can take a break. Oh yeah, there are many questions. Yeah, minute volume is the total amount of air moving in and out of the lungs. Alveolar minute volume is the amount of air that is moving in and out of contact with the alveoli. Okay. Okay. I think people were just clarifying. I think guys have. Does COVID cause inflammation in the alveoli? If yes, then yes. What is that? Yes, it does. It causes some degree of inflammation. It also causes inflammation of the pulmonary vasculature. That is part of its disease spectrum, but don't worry too much about that. One thing perhaps that is important, if you, the height of COVID, I hope not, but some of you may have contracted COVID. I did, even after being vaccinated. And I was asked to lie on my tummy so that it was found that you get better ventilation if you lie on your tummy with COVID. Somehow COVID was affecting the anterior portions of the lungs more than the posterior. And so lying on your tummy allowed you to ventilate better. What else do we have here? Would compliance of lung be less than one filled with water? This, in fact, is in your books. They will compare. We don't have to worry about it too much, because if your lungs are full of water, you're not going to be breathing much. These are theoretical experiments. What people do is that they fill lungs with water to find out what's the difference between the lungs, if there's only compliance or if there's air. What's the difference in work? So because surface tension is removed when you move, when you fill the lungs with water, and the compliance would be less. Why is volume 2000 and not 2550? Yeah. That's very simple. In fact, you can see the diagram. Don't forget this 150 is also going here. That's why it will become when you move this on one side here. You have to add this 150 also. Yeah. That's why it's 700, 2,700. Does still add up with dead air in that space to give 300 minutes? I don't know why we have to do that. I don't understand that question, please. Okay, so if there are no more questions. Class reps, with your permission, can we call it a day and then we meet tomorrow at 12 sharp? Yeah, is that correct?
Wait, you said 12.
I saw 12 on my latest. Yeah, isn't it 12? Here it is.
I thought it was. Let me just confirm. It's 11 to 1 tomorrow.
Oh, is it 11?
Oh no, sorry, 11. It's 11 to 12. And then
No,
from
it's
12
also,
to
it's
yeah?
still me. It's still me 12 to 1. I think 11 to 12
okay.
was Dr. Githinji, and but he moved his lecture. Yeah.
Actually,
So
it's the other way around. It's you 11 to 12, and then Dr.
no,
Gidenji
it has
was
been changed. It was changed. There's a new timetable which you better get from the department. 11 to 12 was Dr. Githinji, or it was me, and then there was Githinji after me, or something like that. But now the latest one shows a blank 11 to 12, and 12 to 1 it's me. So I'll meet you at 12.
Oh, okay.
If it's free, then it's free. You can take a break. Don't worry. Yeah.
Okay,
So I'll see you at 12.
Okay.
Yeah. Okay, fine.